as I said, thank you very much for the invitation today. I'm really pleased to be here. I'm going to start by just reading a short thing that I've written, just to open this, because it's quite a different sort of topic from some of the other papers, and I've really enjoyed dipping into some of those today, as I've been able to through different meetings. But this talk is really about taking us back to hospice and palliative care services, which is what I'm going to think about. And this idea of inclusivity, which I think is quite an important question that we need to ask at the present time. So to be in a situation of seeing a loved one move from often being exhausted, sometimes scared, and usually struggling to cope, to being settled into the care of a hospice lifts a great weight off people's shoulders, including the patient themselves, who is usually more worried about the negative impact of their illness on loved ones than on themselves. Hospices then become spaces where the focus can return to the individual, and they offer a sense of safety and care after sometimes years of acute treatments in hospital settings, where the pace of work really doesn't allow often for an individual focus very easily. And for those who prefer to die at home in their own beds, having the opportunity to achieve this goal should really never be underestimated. So there's much to be proud of and to celebrate during events like this about our hospice and palliative care services. The one thing, however, I think we need to guard against is complacency and thinking we've got everything right. I don't think we have got everything right for everyone, and we need to look where there is more to do. To me, complacency acts like a kind of kryptonite did to Superman, if you remember that. It sort of takes the power away from innovation. It sometimes destroys our drive to challenge or to question what we do or why. And each of us are not immune to becoming complacent ourselves in our everyday work. By looking backwards sometimes, we can see how far we've come, but we also have to think about how much we're not meeting needs that remain important. And this quote from a patient's wife is one that I would just start with. My husband was a quiet man who didn't argue and accepted what was going on because he had no choice. It wasn't his choice, it was everybody else's choice, really. This is from a report called A Different Ending in 2016 in England by the Care Quality Commission. And they were actually looking at the time at the quality of palliative care and asking some of these difficult questions that perhaps those of us who are caught up in the specialty, whether it's acute oncology or whether it's palliative care or sometimes in the territory in between, we find it difficult sometimes to step back and to ask some of these questions. So that's what I'd like to do to end the conference today, by thinking about some of the people who perhaps don't have the choice that others may enjoy. So what do we mean by inclusivity in palliative care? Well, the definition itself is pretty clear. It's a practice or a policy approach of providing equal access to opportunities and resources for people who might otherwise feel excluded or marginalized. And I prefer to extend this definition to the things that we do. So the things that we actually choose to focus on in the way that we work that may further influence equal access to hospice or palliative care services. Now, I don't work in Ireland, and I'm sorry I can't be there today. I would love to have been back in Dublin, but I can comment on some of the work I've managed to read and also draw on some other insights from elsewhere in the world, really. And I looked back, I just had a quick look back at the history of Our Lady's Hospice. I always think history is a good place to start when thinking about some of these contemporary issues. And I did go to Wikipedia, so I'm hoping that this is fairly accurate. And what it says is that the history of your hospice predates many of the others who are often lauded as being the foundation hospices of certainly of Europe, if not beyond that. And the quote in italics caught my eye because around 1879, when the hospice was founded, the incidence of TB, typhoid, and measles in Dublin was very high. And 10 years later, it was claimed that Dublin's death rate was topped only by Calcutta. So Dublin's high mortality rates at the time were attributable in part to the very sick rural people moving to the city in search of care and thus contributing to mortality rates. So by looking back, just by seeing that small insight into the history of the organization that we're connected with now today, you can see that there were people back then who were excluded, partly by poverty, geography, these factors that really were beyond their own control. And out of that situation grew a movement that we're still involved in celebrating and enjoying, if you like, the fruits of today. So people may not always receive the best care, and this is an evidence-based assertion I would say. Again, looking back at the report from the Care Quality Commission in England, they listed people that they felt end-of-life care was perhaps certainly a risk factor, and sometimes there was evidence that already they were disadvantaged in terms of their access. So we've heard today a lot about cancer, and that's understandable given the focus of the study day, but there are many, many conditions that also lead to end-of-life care needs, but perhaps are not always managed quite so well. Older people, I really enjoyed the session I managed to hear this morning about personalized care for treatments, oncology treatments, but beyond that, care homes and people who live alone with comorbidities, they may not always access the services available to others. People with dementia, we've heard some mention of those people today, and I have personal experience of seeing someone very dear die from dementia, and how different that process was from somebody who might have a cancer diagnosis and a fairly predictable trajectory towards death. People with a learning disability, again, a group who are known to be more susceptible to certain conditions, including cancers, and therefore their end-of-life experience may be impacted also. Mental health conditions, people increasingly are suffering from problems with their mental health and living long lives with these problems. And so coming to the end of a life, sometimes with unretractable mental health problems. And what does that say about their needs for end-of-life care? Other groups, LGBTQ plus groups, who are known until very recently to have felt excluded and prejudiced when it came to receiving care in some institutions. Black and minority ethnic groups, again, higher rates of cancers, often diagnosed at a later stage, requiring end-of-life care, perhaps not always receiving the quality that they might hope for. People who live without a home, people who live on our streets or elsewhere, again, increasing numbers, and sometimes living with chronic conditions. How do we reach out and care for those people who will reach an end of life? People remanded and imprisoned because of sometimes longer sentences these days. So people living whole lives in custody, reaching the end of their life in those sectors. And then certain groups that we've known perhaps don't always seem to fit our typical profile. I'll be saying a little bit more about some of these groups later, but gypsy travelers are an example of that, who might not be living in a particularly fixed environment. And just to kind of, I was thinking about this in terms of all these groups, just think about how COVID has impacted on these groups. Certainly here in London, I know that there have been major concerns about how COVID has shaped the needs of groups such as these, and it's kind of brought into sharp focus the way that some groups have received less effective or timely care than others, and sometimes that has been quite shocking. PPE, who's been available for and why, vaccination, who's accepting it, who is not understanding it, and why. So these are sometimes complicated questions, but COVID, I think, has acted almost like a kind of focus that's brought some of these issues out into the open. There have been a number of reports to call on. There's no shortage of evidence. This is another one called Dying Without Dignity from 6 years ago now, by the Health Service Ombudsman. Looking at complaints, they always deal with complaints. The top complaint they always receive is communication or miscommunication. But they cite 12 cases in end-of-life care and draw on a diverse collection, some of them from the groups in the previous slide, and again show this idea that dignity should not be treated lightly because it may not be available to all. I've also argued for some time that some cancers enjoy, if that's the right word, a stronger link, natural link with hospice and palliative care services than others do. And one group I've always felt were somehow disadvantaged was hematological cancers. And I've thought about this, written about it, done some work on it. How do you provide end-of-life care to a condition that can fluctuate so quickly and is always amenable to more blood treatment, more antibiotics, whatever it might be? So some groups, like these patients, are more destined to die in a hospital. They're unlikely to benefit from hospice, although they may benefit from palliative care input. But it's just this idea that some cancers are perhaps, in terms of that idea of complacency, perhaps we're more attuned to some than we are to others. And when it comes to policy and practice, we know that when we think about hospice at home services, and I'm sure this is the same in Ireland, demand always outstrips supply. In one catchment area from this study by Buck et al., 53% in the hospice at home service had a cancer diagnosis, whereas only 11% did not, and the others would have been other chronic conditions, I suspect. But it shows the questions that perhaps we need to ask. When it comes to deprivation and equality, the most deprived cancer deaths, when it comes to cancer deaths, are 18% more likely to be in a hospital when they die, with an average of 5 emergency admissions in the last year of life. So that means going into an emergency department, etc., and all that means when your condition is gradually fading. And also, the bottom line is that the economics of end-of-life care are also relevant, as there is a cost to these hospital admissions, and Macmillan Cancer Support have estimated it's just under £5 million per annum. It could certainly be higher. This is the UK, obviously. When you look at hospices themselves, there's just one project I want to mention that I did some time ago in just outside of London, where the hospices there were asking about, they were worried about diversity, whether they were inclusive, and what people thought of their services. So we sought opinions from a range of what we might think of as marginalized communities. So these were minority, ethnic, and faith groups, physical and mental conditions, gypsy travellers, homeless services, and the local prisons. We did telephone interviews, online survey, and focus groups. And we were really looking at people's perceptions of hospices, whether there were any barriers or things that they might find useful in the future. What they say probably doesn't surprise us, but they thought mainly that hospices were primarily seen as Christian in focus, and their work of the hospice was about death. It wasn't about living, it was about dying. There was a perception that people with cancer were more likely to be referred there, and that some professionals might not refer people there if they didn't fit the typical patient profile. And by that, we said people who might have a limited prognosis and didn't, there was no mismatch in terms of ethnicity or culture. So they were seen by some as safe patients to send to the hospice. There were practical concerns about not having the appropriate food, the caring practices such as personal care or care of the body, and the environment for specific cultural or lifestyle preferences. So very interesting insights from this group. And when we asked about the barriers, some of the things were, don't know anything about hospices. I only know that people do die there. That's all I know. The only route into a hospice is the GP then. I wouldn't know who to go to. This is from a community representative. So say you were a GP and you were Muslim yourself, then you might think, well, I'm not going to refer my Muslim friends here, because you're thinking they don't cater for your religion. So there's a lack of knowledge about the hospice, lack of informational support. Cultural needs were a big concern. People were concerned about the healthcare professionals' own cultural competence. And there were issues of gatekeeping and referral practices that were shaping these people's views. it was also seen very much as a last option. It's a place where one went to die. And for some cultures, it was seen as giving up, that to allow a loved one to go there was seen as given up. And some preferred treatment to always continue in the hospital. You know, there was always something that could be done. And the hospice was perceived as a place where nothing more could be done. And therefore there was a sort of aura of fear that went around this. Now this is in after many years of hospices being established, these attitudes still exist, and I was pretty surprised to hear it. So one of the solutions might be improving knowledge by telling communities what's available, talking about who's entitled to use these services, and looking at how are people referred. Because by looking at all these things, we can ensure that the hospice is responding to the community of which it's part, rather than perhaps being complacent and just doing what it's always done. What we referred or what we suggested needed to be done was that these hospices wanted to engage with these communities. So we suggested they wanted to look at a cultural competence framework with a champion who could look at cultural aspects in a critical but supportive way. They could be more creative and effective community relationships established. And we could look at the different services for the hospice offers and think about what's feasible and in what time frame. And when it came to the hospice and the palliative care service engaging with the local prison, we published a review paper from that study, which looked at the evidence that exists. This was 2012, I think, this paper, for prison palliative care and the needs of those people as they age and need support in the prison. And there were two very clear approaches. In America, it tends to be an in-prison hospice approach. And in the UK, certainly, it was an in-reach service. So people went in as needed. But there were interesting comparisons between those two models that might work for other sectors of the population that appeared in that list that I showed earlier. There's another study I just want to mention from Cardiff University, where I'm based. It's called the Menlok Study, and it's just reported. And it's looking at end-of-life care for people with severe and often enduring mental illness. It's an evidence synthesis. It's drawing on what's out there. And these are basically the summary findings. There needs to be formal and informal partnerships so that to find ways that we can support people with severe mental illness to die how and where they choose. We need to educate, support and supervise staff caring for people with severe mental illness at the end of life. We need programs and services for this group, and it will require a team approach, including advocacy. There were patients on this study, patient advocates on this study who fed into these recommendations. And we also need to think about proactive physical health care for people with severe mental illness so that we can challenge the often cited problem of late diagnosis in these patient groups. Another group we mentioned was the LGBT community, and I think awareness is growing about people's expectations around. This is a book a recent book that's been published from America. It's a very interesting transformational argument that the author Kimberly Acquaviva makes, and saying that a visible commitment to equality, inclusion, and non-discrimination will yield tremendous word-of-mouth benefits. And I've often thought that if you engage with communities and show that you're proud to engage with them, those communities will in turn support the very services that you're providing. Your organization's non-discrimination statement needs to be inclusive and it needs to be visible if it's going to be an effective tool for reaching and welcoming LGBTQ individuals and their families. This should be on every website and pamphlet. This should be showing that our services do not discriminate. And for organizations to be a place where LGBTQ individuals and their families feel safe and comfortable receiving services, it needs to be a place where the employees of the same groups feel safe, comfortable, and valued. So it's not an either or thing. And in that report I mentioned earlier, there were examples of where this is happening, where the hospice embodied all that was good and respected our same-sex relationships. So it's simply a question of respect and recognition. It's not always easy to challenge if it's never been there. But I think our hospices, if we want to include the communities that we serve, we have to acknowledge who those communities actually are and look at them to help us so we can in turn help them. In terms of Ireland, I know that there have been some reports done, and I found these couple of statements that in your own country, there are regions, and I'm sure this is true of all countries, but regions that will have better services and structures at baseline that can then react to funding if it becomes available. So services expanded in a greater extent to places where the services already exist. But if they're not there at all, then those regions' equity has been stymied because you're starting from such a low base. And also the second point here, we need to acknowledge the complexity of strategy. There's no point having strategy without then looking at how complex it is to enact it. So looking at disadvantaged regions, they might not have the right processes from an organizational network or administrative structures. And therefore, if they don't, they might even be further marginalized. So I found this is a really helpful, realistic recommendation made in this report. I think on a wider stage, and this is something I would probably put to all countries, but certainly to Ireland at the moment, is that we need evidence, we need to commission research that it looks at the disparity of experiences in these end of life care for these excluded or at-risk groups, and understand what it is that they are not getting at the present time. Do we name the structural inequalities that exist in our hospice and palliative care services? I think we've started to do it, but I think sometimes it's not easy to do that. It's sometimes easier to just think, it's not a problem for us. We don't really need to think about structural inequalities. We do what we can. And I don't think that really is good enough. We need to consider invisible inequality. And to me, this is due to things like poverty, geography, social isolation, disability, and just simple prejudice. Because each of these can come together and shape the services that we either provide or don't provide for certain groups. And of course, we need evidence-based policy, but policy that is not just about end-of-life care, but brings together things like workforce, training, strategy for change. We need to look at innovation, service innovation in end-of-life care. So there should be a joining up, I would say, of policy. And sometimes policy is seen as a kind of, it's done in separate and unconnected ways so that the parts of the puzzle don't always join up. And to go back to the danger of being complacent in hospice and palliative care, I like this quote, that the tragedy in life is not found in failure, but in complacency, not in doing too much, but doing too little, not in living above your means, but below your capacity. It's not failure, but aiming too low that is life's greatest tragedy. And I think that's a nice quote to think about what it is that we're in danger of thinking or doing or not doing in this field of practice that is so important to everyone's life whenever it's going to be needed. So this is the Bridge Avignon. It's unfinished. It has been for many centuries. It's been a long time since we've been able to travel to places like this. But I thought it was a nice image to finish because there's a lot of unfinished business here when it comes to being an inclusive and equitable service for the future, and to ensure that palliative and end-of-life care really does continue to break those expectations that the founders of this movement stepped up to back in that day when they did that. So thank you very much, and thank you again for the invitation to join in your conference. I hope it's given some food for thought. If it does that, then I'm very happy. Thank you.